Okay, great.
Yeah.
That's so nice.
I thought I'd invite some of my friends because a lot of them are living in Boston. So figured why not.
A lot of us supposed to come, but she's again intensive at Leslie, yeah.
Yeah, I was just gonna press play on my timer.
Yeah, that's great. Thanks. No, I won't move it much. Okay, 4:30. We'll stay on time in this session. Now we have the privilege and pleasure in this next session to hear from some people in our own community who have some particular expertise and a wide range of expertise, but none of them anticipated that the story that they would be telling us in their future would be one about the experience of living with a cancer diagnosis. What we know is that stories let us see something that's different, that's of the human. We know that narrative avoids reductionism. We know that the place and the way that we tell stories is important. And thank you very much for sharing your stories. I will briefly tell you just the names of the 4 panelists we have, and then they'll share their stories with us, and then we'll have time for questions. We have Bridget, who's a former student, who is now studying to be a doctor. We have Woody. We have Laura Campbell, who works in dining services at Boston College currently. And then we have Jim Keenan, who is involved in the public health program and is sharing instead his story of being a different participant in that world. Thank you.
Thank you. Hi, everyone. My name is Bridget. I graduated from Boston College in 2020. So I guess for graduating, I'll be back in 2 weekends for our graduation ceremony. And this is my story. So in the beginning, in 2008, I was in 5th grade and life was great. Sports, friends, school, what could be better? We started to notice some nondescript symptoms, some heavy breathing on exercise. I got an inhaler for sports-induced asthma, a bad winter cough, but who doesn't have one of those? Some large lymph nodes on my neck. The provider said, come back in a few weeks if they don't go down. Keep an eye on that cough. Everything seemed normal. As winter came around, we started to notice some more symptoms. At the end of my year's swim meet, my coach said, are you eating? I was, but I had been losing weight and we just attributed that to swimming. I was a robust kid and it was my first time in a competitive swim league. It looks like you're gasping for air, my dad joked. And it felt like I was. I couldn't put my finger on it. I needed to take more breaths. More strange occurrences on our family vacation to Florida. I couldn't get tan for the life of me. And as we all know up north that if you go to Florida and don't come back a little bit tan, you did your vacation a bit wrong. I had a hacking cough at night too. My family even made me sleep in the living room, propped up with pillows and a cup to spit the cough out. Things were becoming strange, so we decided to see my doctor one last time at the end of break before going back to school, just to make sure everything was fine. I had lost another 10 pounds. My lymph nodes had gotten bigger. My doctor was walking back and forth from my chart, even holding a measuring tape, measuring my neck. They had gotten bigger. He ordered some tests and wrote stat on them. My mom goes, must be like mono or pneumonia, right? He just kind of looked at us and said, we'll see. We're gonna run some tests though. Got the blood work, got the x-ray. Again, weird things. The tech was walking back and forth from my imaging room, bringing different people each time. And we were like, she must be new. Does she know what she's doing? If only we knew what she had seen. Around 9 p.m., the phone call came. My mom called for my dad, and they told me to pack a bag. We were going to the hospital. I'd never been to the hospital for me. What did that mean? How long would we be there? They said to bring a book. I didn't know what was happening. The hospital was a whirlwind. We got to the ER and were practically swarmed, ushered right into a room, IV placed, x-rays and CT scans obtained. I even remember the exact outfit I was wearing, an image seared into my memory on that domed mirror on the ceiling, the outfit I was wearing. People were acting as if I was so sick, but I felt fine. What was going on? At around 11 p.m., an older man came into the room, pulled my parents into the hallway, and that's when I knew something was wrong. I had never seen them so upset when they came back in. The man came over to me and said the words that no one should ever have to hear. He said, "Bridget, you have cancer." "But it's curable," he quickly followed, and I latched onto that. I was never scared. From the very beginning, my oncologist, me, and everyone around me focused on the positives. I think that's the very moment that determined how my journey would play out, always focusing on the silver lining of things. He briefly explained the plan: biopsy the next morning, chemo, inpatient, etc., but I didn't really understand all of it. At the end, he asked me if I had any questions, and I asked him the one thing that was on my mind: would my parents be okay? I never thought about death. I never thought about the possible bad outcomes. Maybe it was childhood innocence, maybe it was optimism, and maybe it was my faith. Whatever it was, I did know that everything would be okay. I kept track of my journey through CaringBridge, and this is one of my entries. I described everything in detail to my fans, and I loved it. I wrote about the procedures I had, explaining what the PICC line felt like, and I even explained what the needle sizes were, including pictures and educating people about gauge sizes. Who does that at 11 years old? I guess the future doctor in me was blossoming. Chemo came and my hair went. As it started to fall, I got a shorter cut to break the ice and to make that jump from hair to bald a bit easier. I said, make it look like Twilight, Alice. That was big at the time. But when I was showering and my hair started to fall out in such big clumps that it grossed me out more than made me sad, I knew that it was time to go. So I shaved it, and my cousin did the sweetest thing. He shaved his head with me. To this day, we're best friends. So during chemo and radiation, I learned a couple more lessons. What does chemo feel like? It's always been tricky to describe to others. There's really no way to describe it until this past January, actually, when I got my COVID vaccine, and that's when I knew. I was crying the night I got my COVID vaccine, and I didn't know why. It wasn't just because of the physical pain I felt, and then it hit me. There's only one other time in my life that I felt that, and it was during chemo. That deep ache in your lower back, your hips, your legs, that of your bone marrow working, the vaccine working and your body responding, that's what chemo felt like. That was the pain. When the Neupogen shots finally kicked in and my marrow sprang back to life, replenishing those rapidly dividing cells, the collateral damage from chemo, that's what it feels like. I was really lucky. I didn't have many of the other side effects that people described. I didn't have nausea, no vomiting, no cold sores. I was just really tired and my hair fell out. But more than that, it was my first introduction to global health and equity. My doctor at the time had a visiting oncologist from Addis Ababa, Ethiopia. They're part of the Aslan project. And they were telling me how kids in Ethiopia and all around the world get sick just like me, but they experience barriers to care that impact their ability to survive, to beat their cancer, and to be a kid again. I learned for the first time factors such as increased distance to hospitals, lack of privacy, shortage of treatment supplies and funding difficulties, provider shortages, and so much more. How unfair was it that me and other children around the world, just by luck of the draw where we were born, have such a different outcome. By July, I reached remission. The focus then shifted from curing me to making sure I stayed healthy. Screenings for secondary cancers, CT scans, x-rays, blood work, echoes, EKGs, genetic testing, ultrasounds, and more. So much was done to make sure my physical health was fine, but there's so much more to survivorship than your physical health. Cancer's more than just getting sick and getting better. What about the fears that consume my mind when I feel a lump or a bump? When I got mono and I immediately assumed the worst? The survivor's guilt I feel when I hear about those who pass? Why did I survive? Do I have to do something spectacular to make my life count? Can I have a family? What if I get another cancer and this time it wins? Cancer's a life event. It's one that I explored with 19 wonderful participants over my senior year here at Boston College. We explored the ways that cancer continues to impact us. Some folks hold being a survivor to the very core of their identity, and others more or less have moved on. But the same underlying questions, fears, and creeping thoughts unite us all. Oh, sorry. There's a missing slide, but I will keep reading. Cancer also connected me to one of my favorite places on earth, Camp Good Days and Special Times. It's a camp in upstate New York for children and families affected by cancer. My favorite weeks of the year are the ones I spend there, once as a camper and now as a counselor. I love seeing my campers, helping them be normal kids again, having fun and laughing. But they too share those fears and uncertainties. One summer, a camper came up to me and said, "If every child here has had cancer, why have none of the adults?" Her unspoken question made my heart sink. What happens to children after they have cancer? Being a survivor isn't something that's necessarily tattooed across one's forehead, and it's scary to not know what happens next. So much focus is on beating cancer, not so much on what happens next. But that camper's face lit up when I showed her my picture from my first year at camp when I was bald, just like her. But unfortunately, just as much as there's happiness and hope and courage, there can be sadness. Some years I say goodbye to campers, and that's the last time that they come to camp. I've known in my heart for as long as I've thought about medicine that I would be a pediatric oncologist, following my own footsteps, being as patient-centered and family-focused as he was, for my future patients, for children like my campers, and for children like me. Am I lucky to have had cancer? In a weird way, I would say yes. Everything that I do in life, everything that matters to me, it's all related to my cancer. The service I do, my career goals, and even my interests. I had began to learn about equity and justice through my cancer, and today equity, justice, and advocacy consume most of my thoughts, just as much, and maybe even a little bit more than studying. What seemed like forever, my dream of becoming a doctor was in the far off distance, but now it's a reality. The one email that made me cry of happiness more than my first medical school acceptance was this one right here from my oncologist, where he signed "your colleague." I still tear up thinking about it. I'm now a second-year medical student at Boston University School of Medicine, and every day I love medicine more, I love my patients more, and I'm more excited to be their doctor. I know I'm where I'm meant to be, and I can't imagine any other life circumstance, good or bad, that could have brought me here. At BC, we perfected, well, maybe not perfected, but we practiced quite a bit answering, or our ability to ask these three questions and to answer them honestly. What brings you joy? What are you good at? And what does the world need you to do? Because of my journey and my health experiences, I know that I can answer that question honestly and with the most confidence, now more than ever. From patient to future provider, my cancer journey shaped who I am and who I'm meant to be. for better or for worse, in sickness and in health, and till death do us part, cancer is a part of me. Thank you.
All right. First of all, I want to thank you, Andrea and BC, for having us all here to speak. I really appreciate it, and it's a good little excuse to come back to the old stomping grounds. So thanks for having us. Hi, I'm Woody Hubbell. I'm BC class of 2021, so just graduated a few months ago, and I'm a cancer survivor. So growing up, I grew up in Minnesota, and I always enjoyed playing sports, being active, doing things outside. And then I guess we can hold that off for a second. But then I ended up coming out to Boston College because one, I always wanted to come to school out on the East Coast just to experience something new. And BC is very similar to my high school. I grew up Catholic, went to a private school, and BC is a very good education. So freshman year, I had a great time. Typical freshman year, there's a lot of adjusting, being away from home, never lived away from home for very long. But I was excited to come back for sophomore year. So one day, sophomore year of college, I was at the gym playing basketball with some friends, and I was noticing I was getting a little bit more tired than I normally would. At first, I thought, hey, maybe I'm getting out of shape. Maybe I need to come to the gym more. Who knows? But then it eventually got to the point where I went to health services at BC, and I was initially diagnosed with strep throat. Just a quick test, given some antibiotics, and that was that. About 2 weeks later, I had finished up my antibiotics, and immediately, almost the second I stopped taking them, I felt just as sick as I did before. And at that point, I went into health services again. And, you know, it was hard to tell what was going on. I had never really had health problems or, you know, anything in my medical history. And so the doctor simply took a blood sample and then said he would get back to me in 2 to 3 days. At this point, it was the end of first semester and my sophomore year. And I was studying for my first accounting final, actually. I remember it like it was yesterday. And one of my roommates had walked into where I was studying and said, hey, our RD just came into our room and said, you need to go to health services now. And I thought, that's an odd request. I don't know why they'd be needing my presence at health services, but okay. And so I walked over there, and as I was walking over there, I just thought to myself, you know, I don't know exactly what's going on. I don't know what this sickness is or what it could be, but maybe, just maybe it could get me out of finals. So fingers crossed. Bottom line, it did. I was diagnosed with acute lymphoblastic leukemia, and I had spent the next 34 days inpatient at Brigham and Women's Hospital over in Longwood. I would say the hardest part about my entire treatment process was, you know, obviously the first few days and just figuring everything out and exactly what's going on. You know, I was a 19-year-old kid, so I was very confused, far away from home, but also just telling friends and family, professors as well, that, hey, I'm not gonna be able to take your final. Something came up. But also, on a lighter note, it was really cool to see not only my family and friends come together, but the BC community as a whole. I had tons of friends come and visit me in the hospital for those 34 days. My family came for the holidays, and we were all jam-packed into one hospital room, which was great. And then even some of my professors as well. So that was really cool to see. After that month, I left school for a year on medical leave of absence, and I received treatment at home at the University of Minnesota. I was excited to be out of the hospital, I was also missing out on the BC experience. You know, I just started up my sophomore year, kind of just finding my footing with making new friends and getting into the swing of things. And that had all come to a quick stop. So it was hard not to have a little bit of FOMO in that sense. While I was sad that I was out of school, my friends and family did a good job of making me feel included. Some of my high school friends actually made a banner for me and sent it around to different college campuses and took photos with it. And so it was really cool to see that kind of community bond. That was awesome. So after 1 year of outpatient treatment at the University of Minnesota, I had been deemed fully in remission, but with the protocol of leukemia, I had to keep getting treatment for the next 3 years. So I came back to Boston College a year after being diagnosed and was balancing schoolwork as well as going to the hospital once to twice a week, having infusions as well as taking chemo orally. I was incredibly nervous coming back to school because I'd been out of school for a full year. You know, as much as I was trying to stay up to date with my education, it was just not the same as, you know, being in school. I'd never been out that long before. And so when I had moved back in, I moved into a dorm room by myself because I was still immunocompromised. But when I moved back in, I started thinking to myself, what if I can't handle this? What if this is too much? What if I'm just not as smart as I was a year ago? Who knows? So I was incredibly nervous. But that all came to a quick stop when one of the first weekends of that semester, I went to Mass, and Father Tony Penna was saying Mass that day. Some of you may know him. But he was someone who became a close friend over my treatment process, as he came and gave me the Eucharist a handful of times in the hospital. So I came to his Mass, and I saw him at the beginning of Mass and said a quick hello, and then we started up Mass. Good to be back. Tony said a great Mass. Can't say I recall what the homily was, but he spoke very eloquently, as he always does. And then at the end of Mass, Tony just gave me a quick little shout out and said, hey everyone, we have a familiar face with us today, Woody. Let's welcome him back. He was on a medical leave of absence, and there was a small round of applause, and I gave a quick wave, and that was that. I was there with my girlfriend, and then we walked back to my dorm room. I didn't really say much, but then the second I got into my room, I just started burst out crying. And I just thought to myself, how am I so incredibly lucky to be in a community like this where all of these people who don't even know me are saying, hey, congratulations, we're with you. We've never met you, but we love you, essentially. And it was in that moment where I thought, I'm just in an awesome community. There was still a lot of treatment that I had to go through, but at that point, I really felt that I had a community behind me. So then I got back into the swing of things and balanced school as well as going to the hospital. And then another barrier came with COVID, and I would always go into my hospital visits either with my girlfriend or with my mom, and they were just a nice person to have there for an extra piece of emotional support. Obviously, when COVID struck, hospitals had a lot tighter restrictions as they needed to have, and they could no longer come and visit with me. At this point, luckily for me, I had already built up a relationship with my team of doctors and nurses. At this point, I was receiving care at Dana-Farber. So I was lucky to have good relationships, but it made me really feel for people that may be just starting out their process. Maybe they're just being diagnosed and they have to be inpatient for a month and a half just by themselves. I was lucky enough to have my family and friends come and visit me, but other people might not be so lucky. And another instance in which I felt incredibly lucky was that I was able to receive medical care at some of the best hospitals in the country and even the world, just because they're in BC's backyard. I was down south over New Year's with my family, and I was still immunocompromised, but I was diagnosed with pneumonia, and I was just feeling incredibly sick. The doctors down there were doing a great job, but they just didn't have the same infrastructure that we have here in Boston. So the recovery process took longer than it would have if I had been up here. And that once again reiterated the fact that, care is not equal everywhere. Obviously, they were doing their best, but the infrastructure just was not in place. So that was something that I felt, I'm an incredibly lucky person for being able to have care from some of the best hospitals around. And with that, just looking back on my recovery process, I had my final chemo treatment this last May, and then I graduated that same week. So it was a very big emotional week, sad saying goodbye to some friends, as now I'm living back in Minneapolis. Sad saying goodbye to my medical team as well. But one thing from looking back on this whole journey is just, it really does take a village. Going back to Father Tony, I took his class my junior year at BC. He has a theology class. And he would always speak about how life is like climbing a mountain. Every day you start off at the base level, every day you're climbing just a little bit, a little bit, a little bit. And then suddenly one day you look and you're at the top of the mountain and you have a whole new perspective on life. You can see way farther than you could before. So relating that to my treatment process, I was, taking this climb up the metaphorical mountain with an entire community behind me. And many times the community around me was carrying me up said mountain. I'm lucky enough to have some of my friends here today who have been along for the ride, and it's been awesome. But with that being said, it really is something to be noted that this community really helped change my life, and now I have an entirely new perspective. And thank you.
Hi, everybody. My name is Laura Campbell, and I work here in catering at Boston College. I was diagnosed with breast cancer in November of 2017. A cancer diagnosis is paralyzing. The words are suspended in air. When the doctor confirms, yes, it is breast cancer, you are stunned. And when the mental processing begins, you start to panic. Thank you. Am I going to die? Will I need chemotherapy? Will I lose my hair? What about my family, my husband and my daughter? Why me? All these private thoughts take seconds until you gather yourself, take a deep breath, pull up your bootstraps, and ask your doctor what's next. For my breast cancer, ductal carcinoma in situ, or DCIS, a contained cancer in the breast ducts. My cancer cells started to break free from the in situ part, thus requiring lymph node removal during my surgery, my lumpectomy surgery, to see if any of the escape cells made their trek elsewhere in my body. Thankfully, they didn't. The cancer was contained, removed with clean margins, and only requiring 21 radiation treatments, commencing 1 month after my surgery. I'm also taking the drug anastrozole for 5 years as my cancer was estrogen positive. I am blessed to be here to tell my story. Early detection is paramount. It saved my life. I am grateful for the excellent care of my medical team at the Beth Israel Hospital in Boston and in Needham. They provided me with medical expertise, compassion, and encouragement when I needed it most, and still do to this day. I am also extremely grateful to have the health insurance that Boston College offers its employees. My financial worries were non-existent, as cancer is very, very expensive. I am a 3-year breast cancer survivor. I still have my fears and anxieties as my yearly mammogram approaches. The weeks leading up to this day are challenging. Some days I'm inconsolable. I go to ground, I cry, I scream, and I can get nasty to those closest to me. I wish I didn't behave this way, but I do. But without the love and support of those closest to me, my husband Rick in particular, I don't think my outcome would have been as positive. He was and continues to be my rock. Even before you hear these fateful words, you have cancer. You endure the maybe it's cancer journey that starts with the dreaded call from the hospital. We need you to come back for more imaging. We need to do an ultrasound. We need to do a needle biopsy. We need to do a breast MRI. Now we need to do a guided MRI biopsy. Well, you know the rest. It's a mentally challenging, paralyzing waiting game. If only there was a way to move this process along more smoothly and humanely. You constantly hold your breath and wait. And there's a song that some of you may know, some may not, by Tom Petty, called "The Waiting is the Hardest Part." And that is the truth. Lastly, what I've learned from this experience is that life is fleeting. We must live in this moment, for this moment is all we have. So to all of you, take that trip, use the fine china, go for that walk, don't hold a grudge, call that friend, always be kind, make plans, do not wait until you retire, do it now. A close friend of mine, also a breast cancer survivor, once said to me, "Laura, we are all 5 minutes away." How true a statement for us all. I wish all of you good health. Thank you for this invitation to speak, Andrea. Thank you, and to allow me to share my story. Thank you.
In October 2006, I was told that I had a very thin melanoma on my back. And when it was removed, I was told afterwards that the borders were all clean and I was fine. I had beaten melanoma. It was stage 1, and that only 2% of people with a stage 1 melanoma would ever find themselves in a compromised state. Needless to say, I'm up here because I did. In August 2008, I found a swollen lymph node in my groin while traveling in Europe. And on August 26th, having returned to the United States immediately, a 3-inch tumor was removed and biopsied. And I was diagnosed 2 days later with a stage 3 at least melanoma, possibly stage 4. It was not a recurrence. It was rather that my cancer had migrated before it was removed. And it fortunately located itself in my sentinel node where it stayed. I was slated for a deep lymph node dissection in September, on September 26, 1 month after the biopsy had been done. And in the month of waiting, I had 2 scans for brain tumors, one for a possible pulmonary embolism and one for deep vein thrombosis. So you, like all of you, you know all the tests that you get, and it's kind of like it's extra benefits. Here I was, though, a white man being treated at MGH, and yet my odds of survival were not all that great. During my surgery, When I awakened from it, I found out that indeed my cancer had not spread. I had been walking around for 2 years with an untreated advanced melanoma, and it had not spread. So you can imagine how grateful I was. But I began then a 12-month regimen of interferon, which I can share with you is an awful experience. I had to inject myself 3 times a week. And my physician would say to me, you're going to experience flu-like symptoms. It seems so gentle, but if you inject yourself each time for a whole year with something that's going to give you flu-like symptoms, which really are flu-like symptoms, they don't sound all that easy, it's difficult. During that time, I also was hospitalized, significant hospitalizations twice for an advanced cellulitis. My immune system was completely compromised. Putting this together here, I have to say that I have to talk from another vantage point. I teach on HIV, AIDS, and ethics. This is a disease that has enormous social ramifications. People who have HIV want to know who they got it from. I didn't get my cancer from anyone. People who have COVID would love to know who they got it from. And they will also compare notes about that. But with my cancer, it wasn't. And in fact, I began to refer to my cancer as my cancer. Most people don't refer to their COVID or their HIV as theirs. But in order for me to survive, I had to call it my cancer. It was singular. The experience of having cancer is a very private. This is why we're so grateful for people reaching out to us. It's not a social experience that you find in the phenomenon of contagious diseases. It's a very different disease, and bringing it into the ambit of public health, I think, is a significant move, not only because of able to address questions of prevention and treatment, but for the social recognition of the patient. As a patient, I never had any experience other than what an individual did, or like in Woody's case, you're coming out to him, or in your case, Laura, people coming to you, your family. But there isn't a social structure that acknowledges that. The insularity of having cancer is something that global public health has to acknowledge. It has to somehow embrace the patient in her or his experience as knowing that it's radically insulating, because you're always asking yourself the question that someone with a contagious disease has a very different answer is, why me? How did I get it? I'll conclude just saying this. You know, statistics. I was told after they removed it from my back, 1% to 2% people end up having a serious melanoma. 2 years later, I had one. Statistics, when I hear them, really don't matter anymore because it was my cancer. But at this conference, we're being invited to call it our cancer, and I welcome the initiative. Thank you.
Thank you, panelists. I regularly attend the International Conference on Communication in Healthcare, and we always invite people to tell their stories who've experienced different aspects of healthcare and sharing stories. And I study where relationships meet. And it's very easy for you now with this experience to see where the human stories meet the academic stuff we can get lost in. Now we have some time for questions.
Thank you all. That was very moving, but also positive with lots of hope. I worked in oncology in the mid-'80s, and we introduced a new service on our oncology ward with psychosocial support. So really taking care of the individual needs of the patients and with all their questions. Why me? That is always the first question. It's also taking care of all the kind of ramifications with regards to employment, with family, et cetera, Even in a well-done healthcare system, there are issues. Can I get back to my work, etc.? How did you experience that in your situation? Is such a kind of a support service available? You talked largely about your doctor, who typically doesn't have the time to take care of that, or about the family support or the community support. Is there any professional support that you had experienced?
I joined a cancer support group, more like a one-on-one, shortly after I started radiation. And I still meet with her every 2 weeks, and I would be lost without it. She's always very supportive, but puts me right again. It's like a spiritual shot in the arm every 2 weeks.
Yes, for me, when I was inpatient and also going and receiving treatment, I had many different, I guess, health coaches, you could call them, come in and just talk to me and make sure that I was healthy mentally, and because obviously it's a big process to go through, and it can be lonely sometimes. But I thought where I was receiving care did a really good job of providing resources in that sense.
Yeah, for me too. I think it was very unique because I was so young, so I didn't necessarily have the am I missing work and all those higher thoughts that for better or for worse we get when we're older. Um, but still it was strange to not be able to participate in like the youth sports and the things that at that time were really important. And same thing, I was really lucky with my family and my friends, and my school people kept me as involved and included as they could. And that's one thing that I would agree I wish we had more of is after treatment and after cancer to continue like support groups such as that. I think the young adult world is really lacking, and that's what I focused on in my senior thesis.
I'd say that there's a difference in what I would call a social embrace of the cancer patient. I think it's an interesting phenomenon that after HIV broke, that that breast cancer and women together developed a solidarity among themselves that we've heard about here at this conference that's really significant. And somehow you could come out with having breast cancer. But I would say that in many instances, people who are treated for cancer do not have that some sense of solidarity with other than your friends or family. They don't necessarily have a lot with their fellow patients because they haven't, at least in my instance of melanoma, met them. I remember my niece died in 1999 at 19 in Children's Hospital. She was surrounded by a professional staff. She was surrounded by her friends, but there were no other leukemia patients with her. The phenomenon of people as patient with other patients is a very significant concept in global public health, but it's not yet in cancer. Except for breast cancer. That's why I thought that Professor Williams' remarks earlier today were very, very significant. A solidarity, like I've talked to one person about his experience with melanoma. Being able to share your experience with, your experience of breast cancer is exactly that. There's not a solidarity among patients who, in most areas of cancer. They have the partnering with friends and family, all sorts of outreach, but there's not that social phenomenon that we see with other public health illnesses.
Jim, how would you propose we catalyze that?
I think this conference is a good step toward that. I never thought of cancer as a public health issue. I thought of it as my issue, because it was my cancer. And I think that's the way it's so privatized, cancer. It's not that public. When you hear global public health, you think HIV, you think of COVID, you think of pneumonia, you think of airborne illnesses, you think of anything that's contagious. Contagion seems to define that, and that's because it brings something social. I just think that we need to embrace this more often. So like today, earlier, there was a fellow here named Professor Rojas who gave a really wonderful, he talked about the difference between prevention and treatment. And I was dying for him to make an analogy, say with HIV, that as a matter of fact, if we did more on prevention, we wouldn't have to do as much as we're doing on treatment. But he never made that analogy. I do think it's important in talking about cancer that we make analogies between cancer as an illness that has connections with other more socially oriented illnesses.
I also wonder your comment. I have a kid who came home from school in the 2nd grade, and he's like, "So I'm sitting by Christian." Everybody knew that Christian had cancer, and the parents were concerned. They didn't want Christian at school because Christian was sick. And he's like, "What I know of myself, Mom, is that I sit by Christian because I'm able to make jokes with Christian, and I don't have to focus only on the cancer." And there was recently a World Health Organization group that's putting together what are we missing in social determinants of health. And what they focus on is how do stories tell us something that's different. And I wonder if you have comments of the things that you wish we would know that it's social, but it also means taking your lead of when you want to talk about it and when you want to be supported and being still Jim.
I just think though, watching each of us, so this is the first time today all the panelists are sitting with one another. I think that's significant. We want to be in solidarity with one another. For me to hear your experiences is really profoundly touching. We've been so alienated in our treatment that we don't do it publicly on cancer. We do it with one another, you know, with family members and stuff like that, but we don't really have a place to understand this much more socially. I think that's why we're, you know, like your friends here. This is really significant to have them here. This is a way that all of us recognize. In order for me, I had to go for my first 30 days every day to get 60 milligrams. I can remember it now, of interferon that was being pumped into me. It was an awful event. And I would be treated for, it would take about 3 hours to get me in and out. And I had all these friends here at Boston College who said, "What can I do for you?" So I said, "You can take one day, one of my 30 days, and drive me and stay with me and be with me the entire day." Then they saw what the bloody flu-like symptoms were. And they were like really empathetic and really concerned. But that partnering was so significant. However, after that, I was on my own. And I think many of us were on our own at different phases. We may have friends, but we don't have other patients' experiences shared. There's a certain phenomenon of reading about other people who've had an illness that you have, you know, to talk about COVID or to talk about HIV or other, that's really helpful and sustaining. And you can see, obviously, how vulnerable each of us have been and how significant that partnering was. But we were not partnered by fellow patients. And that's part of the social structures of our healthcare system.
Thank you. That doesn't cost $32 billion.
Can I add a couple of thoughts to that? Yeah, that's something I think about a lot, is how cancer is so everywhere. We've all known people with it. 1 in 2 men, 1 in 3 women will have cancer, but it's so unique. We all talk about it. It's my cancer. It's my journey, my this. And there's a couple things that I always think about that play into that. And one is, I think in comparison to other illnesses, there's this strange like hierarchy of what you call someone who has suffered, been treated for any type of illness. And for a lot of cancer patients, I don't want to speak for everyone else, but it's a weird hero complex. And you say, "I've had cancer," and people throw all these adjectives at you, and you're like, that's not me. And so we don't lead with that. There's no other illness where the second you say, "I've had a pulmonary embolism, I've had a this or that," no one's like, "Oh my gosh, you're so strong, you're so this." And I know it's as humans, it's our nature to want to be warm and fuzzy and to lift people up, but that social, almost like awkwardness of I don't know how to greet someone appropriately prevents people from sharing a lot. Like I don't share my story with people because exactly that their view of me switches in an instant. And I don't want that. I don't want them to see me first as this, something that I couldn't control in the same way that someone can't control a pulmonary embolism. Like I don't want people to view me differently because of that. And so I think that plays into this strange isolation, but with everyone else. It's like we're all in tiny pills in a pill bottle. We're all together, but separated. And for a lot of people that I've talked to, if someone has either a good view, they think of their life as being positively changed, or negatively changed, they just wanted to get done with their cancer. Everyone always had one moment of being able to kind of cross the hump of being like, it's going to be okay. And I know that I can look on this and be like, oh, it's great. Or I can look on it and just move on. And they don't harbor on the negatives. And the moment that everyone attributes to being able to do that is having connected with other cancer patients in some way. So I don't know the solution, but I know it's really important to connect and to be social and to have that embeddedness.
So thank you very much for sharing about your life experience. And you were at BC, or you are at BC. If we think about BC as a place of formation, is there something else we should do in light of what we are discussing in terms of helping us to accompany one another, not only in the terms of friendships, but in terms of formation, when we are aware that in our midst there are persons who have cancer or will be diagnosed with cancer? And how can we help the whole community to find a way to help in dealing with these human experiences and social and regarding care that can become opportunities for formation?
Yeah, I agree with what's been said so far. I feel like talking about cancer is, a very rare thing, because every time that I've spoken about when I had cancer, it has been me bringing it up. No one else wants to bring it up, even if they know that I had cancer. So I think that something like this is incredibly important, and just opening up the conversation. But that being said, I felt that BC did a really good job when I was coming back to school, in making me feel like I was back to regular life. I had met with a few people from um, mental health clubs at BC who just checked in and made sure everything was going okay. I had a good dialogue with professors saying, hey, on these dates, I'm going to be at the hospital. Please let me know if anything's going on. But it is interesting because I guess it can depend on the person, and saying, hey, why are you missing class? And then someone brings up that they have cancer. It's a whole different thing than, hey, sorry, I slept through class. So I do think it's just important to have an open line of communication about it. And I think that this is an awesome start.
Yes, when I was going through my treatments, before, when I first found out I had breast cancer, I work in catering, and speaking with my manager, it's hard to talk to someone. There's one woman there that I felt comfortable talking to about it, but they were wonderful to me. They, whatever you need, we're here for you. And I missed a lot of time going for my treatments. I went for 5 weeks, and I would leave here at like 12:30 for 1 o'clock. I went to the Needham BI for my radiation. So I would I would come into work and leave to go for my treatment and go home. And when I got my review and I missed all that time, they said, we're wiping it off the slate. It's not even going, it's not even counted, because we know what you went through, and you showed up for work. You showed up and did it. So they were very, very supportive of me. And I do believe that at one time I was talking to Pat Tuzin, there was a breast cancer group here, run by that And I don't know if that's even still happening, but it would be a nice thing to have for people, because I know I'm not the only one on campus that's had breast cancer or any cancer. I mean, I think we're social creatures. We need to stick together. We need to be with each other, share our stories, and know that there's hope. And cancer isn't a death sentence. If it's caught early, you can get through it and you'll be fine on the other end. And I think people need to know that, and your mindset, it's so important. That whole mind-body experience is very, very, very important. And the more we talk about it and the more we share our stories, knowing you're not alone is very important.
Just to follow up on that, I remember when I first had to figure out what I was doing with my cancer. I didn't know. I was teaching a course on HIV, and I had a completely compromised immune system, and I'm injecting myself every other day with interferon for a year. So it was kind of a miserable time. And but I didn't know how to act. I didn't know when I was supposed to say to students, like I did say to my students, please, if you have a cold, if you have the flu, stay in the back. I have no immune system. Then they come up to me hacking all over the place, and I go, I really don't have any immune system. And none of us were wearing masks at the time. And so, but I started a way of talking about my cancer. I tried to talk about my cancer, and it was taking me a while. And finally, I told a friend that I wanted to say something to her. I said, I need to tell you about my cancer. It was my first time coming out, talking about my cancer. And her first words were, I would never call it my cancer. I was so astonished. She was correcting me, trying to explain what was going on with me. And I said, you're right. It's not your cancer. It's mine. And that's the phenomenon that I think we're talking about, that in one way, we're afraid of somebody correcting us as to how we're actually handling what we're doing. Oh, you should be thinking more bright thoughts, you know, those type of silly things. There's a certain way that people don't know how to talk about cancer publicly. And I think that that's one of the reasons for the silence. And at least fellow patients do know how to do that. And then our own collectives, but we're still in insular or we're in collectives.
Thank you very much.
All right, well, thank you very much for sticking around for the last session, and I greatly appreciate the stories the last panel shared with us. Yeah, this is why we're here, right? This is why we do the work we do, to help those suffering from these devastating diseases. Now we're going to change gears a little bit. My name is Glenn Gaudette. I'm the chair of the new engineering department here at Boston College. And it's a pleasure to be here with you today. Our last session for the day is looking at the future. And we have two speakers in the session. The first one will be joining us via Zoom. And so our first speaker is going to talk about a global strategy for eliminating cervical cancer challenges and opportunities. And it's Dr. Sylvia de San Jose from the National Cancer Institute. And then she'll be followed by Dr. John Hart from Loyola University in Chicago, who will talk about an ethical agenda for the future. And so I will hand it on over. It's all yours, Sylvia.
Hello, thank you very much for inviting me to joining you on your awareness about the epidemic of cancer worldwide. And I would like to thank as well Dr. Kurt Streif, because he invited me to attend, and I have been listening some of the sessions, extremely interesting. So I can share my presentation. Let me see if I can manage. Yeah. Okay. So I am an epidemiologist. I have been working for the last 30 years on cervical cancer prevention. We have been involved in identifying the etiology of this cancer. We have been observing throughout these years the production of the discovery and the production of vaccines, that they are amazingly effective. And still we have a major issue that many women are dying today of a disease that's clearly preventable. So I will try in these 20 minutes to try to bring the key issues that we are concerned and how we can move forward trying to prevent this disease. So last year, WHO launched the global strategy to accelerate the elimination of cervical cancer. And we have here the Teal sisters from Zambia, who really try to bring energy. These are women that they are survivors of cervical cancer. And they really try to bring everybody in the same level of awareness, and showing to many of the governments that cervical cancer is present, and it's particularly a major issue in low resource settings. And we will go over about these issues. The launching was very followed by many countries with many events. The problem of the elimination campaign is that it's a wish list, and we have to, as a scientist and as an epidemiologist, I always like to see that the steps that we want to take are really balanced, and that they follow the reality of the societies and of the technology. But it is important to say that this launch was important because many governments would not even recognize this disease as an important public health problem. Unfortunately, it coincided very closely with the pandemic, and that has generated a lot of problems and issues, as with many other public health interventions. But I think the people working on all the atmosphere of trying to prevent cervical cancer are still very motivated and trying to do the best to not to forget about this disease. So the elimination is, as I said, is a wish list, but it's a wish list that is based on some analytical approach, that if we do not modify our activity in terms of cervical cancer prevention, we will see that after 100 years, when we change the century, the incidence of cervical cancer will be more or less what we are observing nowadays. If we can intensify the introduction of the vaccines, we can see a really sharp decrease of cervical cancer in 100 years. If to the vaccination we add secondary prevention interventions that includes screening, the change in the scenario, the change in the burden of disease can really be accelerated and be reduced. The idea is to reach an incidence of cervical cancer of 4 per 100,000, which is it's a threshold that some few countries in the world are already at these levels, in particularly some of the Arab countries, because they have very low risk for the disease. But some rich countries are moving fast to this level of disease, and we are in 2021. So many cases are in showing us the phases of cervical cancer in the rich countries, like this lady in Ireland who had a problem with a cervical cancer screening that was not adequately diagnosed, and it was a failure of the system. But in many occasions, what we are seeing are women that have not at all any access to preventive strategies. So much that cervical cancer has drawn in this map and is shown in deep colors, dark blue, the areas in the world where the incidence is really very high. And you can see the distribution of the blue is really dramatic. No, in sub-Saharan Africa, very high rates, very deep blue. In some countries in Latin America, in the Pacific Islands, Marshall Islands, for example, among the highest incidence rates of the world. And if we were going to see the map of mortality, we would see that about 80% of the women with this disease are going to die, and 50%, sorry, and 80% of the deaths will originate from sub-Saharan Africa, Latin America, and Pacific Islands. So cervical cancer today is considered one of the best indicator of inequality in health. And this inequality is largely, as I show you in the map, defined by the place of birth. We have an unequal public health involvement in cervical cancer prevention. Many countries with low resource abilities, they have the urgency to manage acute disease, and they have very few programs on chronic diseases like cervical cancer or breast cancer or colon cancer, diseases in which we can intervene. There is a real lack of public health money to include the whole population. As well, there is an inequality in access to health when we see rural and urban situations, and then as well public and private. Obviously, there is inequality in some countries with low resource settings. We still find that there is a very good care in the private sector, but public sector is really abandoned. And what I would like to point out is that as well, some of the scientific knowledge that we acquire in rich countries is very difficult. It has a lot of barriers to be translated into knowledge, into implementation in low resource settings, which is really astonishing sometimes how long it takes to bring our knowledge to some areas that they really need that information. We know that cervical cancer, we know a lot about cervical cancer. We know the cause of this disease is an infectious disease, is the human papillomavirus. You have heard before Professor Shankar talking about vaccination. And it is about 200 different viruses. Now we are all aware of viruses and infections, and HPV is a large family, but it has only about 13 types that they are from this alpha species, that they are really causing cancer, and that they are the ones that we need to handle. Many other papillomavirus live with us and do not induce any disease, and we don't need to worry. But these particular types, particularly the 16, it's one of the most potent carcinogens that we know in human biology. We have learned a lot about the cervical model of carcinogenesis. We know how to identify what we call the 4 steps from normal. This is a cervix, uterine, and we can see the cells that they are extracted from this organ. And by looking at the cells, by studying the cells, by studying the molecular biology of these cells, we can understand where we are in a normal situation, in an infection, acute infection state, in a precancerous state, or in an invasive state. We know today that if we handle the disease and the infection at this level, we really have the tool to prevent the jumping into invasive cancer. The most important risk factor is persistence of human papilloma infection for these selected types that I mentioned to you before. We have the tools to prevent this disease through vaccination and through screening and manageable treatment. We know now that self-sampling of these cells in the cervix, the molecular study of these cells, and the introduction of mobile tools and devices for treatment of small lesions, we can manage, I would say, almost 90% of the disease that is affecting the human population. Through vaccination, what is important is to try to vaccinate the cohorts before women are sexually active, because it's when they acquire the infection. You can see here in green, we acquire the HPV infection. Almost everybody that's sexually active has a contact with HPV, but we generally, if our immune system works well, we are able to eliminate this infection. So if we are able to vaccinate before the majority of our population acquires this infection, we can really stop the whole process of acquiring later on cervical disease and later on invasive cervical cancer. However, although we have a fantastic vaccines, we have 3 vaccines in the market. One is coming from China as well, or 2 are coming from China, 1 from India. So we have vaccines in the year 2019. Still, you can see many countries in gray that had not introduced these HPV vaccines, although there is a lot of work by Gavi, which is Alliance of donors, that they provide vaccines at a very low cost for low resource settings. Still, there are many countries that have not yet started vaccination of girls from 9 to 15 years old. And you can see that the gray areas showing no vaccination include many countries in Africa. Russia still, China is start doing some work, but still has not in the year 2019, when we've last reviewed the data, they had not yet introduced the vaccine in a national program. Sorry. As you can see, from 2006, when we launched the commercialization of the vaccines, we see that in rich countries, they include, the majority of them have included the vaccine. We have 70 out of 86 countries. But when we go to the yellow, which is the low income countries, only 11 out of 47 have included or recommend this in their national program. In this graph, you can see in green shows the number of women that they are in the world by age, starting from age 0 to until 100 years old. And the graph is divided between rich countries and rich countries is the right side, and the left side are low and middle income countries. And the pink and blue represent what in the year 2016, which is the work done by Laia Bruni, a colleague in Barcelona, that indicated how many women have been benefited in 2016, 10 years after the introduction of the HPV vaccine, how many were vaccinated. And you can see how few girls had been vaccinated in low resource settings. And contrary, last year, a group in Sweden just published their data. We're one of the first countries to introduce HPV vaccination, and now they can see in this orange or red line that the girls that had not been vaccinated have a much higher disease than the girls that were vaccinated before the age of 17 years old, which we think it's before initiation of sexual activity, and those that they did it a bit later still had a lower incidence of this disease, but a bit higher than if we manage to vaccinate girls at an early period. So the contrast between the two worlds is amazing. And we think we still have over 2,040 million girls that today they don't have any possibility to acquire a vaccine before sexual debut. The other tool we have is, okay, you have missed the vaccination, let's go for a screening, secondary prevention between, we believe that between 30 to 50 years, it's the best target to identify lesions that can develop into cancer. But still in this map, and here instead of blue, we get it in red. Look at how many countries are in red. This is a work done by Laia Bruni again and the team. It took 2 years to extract all the information from all the countries in the world to try to estimate how many women have ever been having a screening test. And you can see in red is less than 10% shown in Africa have ever had a screening test with a Papa Nicolau or with a visual inspection, any tool. So we have really a challenge that only women living in rich countries are getting this screening. We are moving a bit better in Latin American regions, but still the job is really far from being completed. So one of the ideas that we propose is that by means of self-sampling, we can avoid many of the visits, gynecological visits, that may bring another barrier to the women to have access to screening and secondary prevention. We know that cervical cancer screening is increasing just because of the demographic change. So we have to do something. And in addition, we have now COVID. We cannot bring thousands, hundreds of women to clinics that the majority of them will be negative. We need to try to screen women to detect the positives, and the very best approach, and that's our really work, not try to convince that self-sampling is an adequate approach. And we did a study in Central America. We managed to screen over 300,000 women, and the majority use self-sampling, over, I think it was 85 to 90% according of the countries. They were keen in learning, keen in doing something that they could manage by themselves, that it could save them to go to lose 1 day or even 2 days, to lose the salary of what a working day, to have to take the children to the medical center. Self-sampling is really a good approach, and it can help us. And the only thing we can say to use self-sampling is because we can run a molecular test. We can detect the infection in these cells and make sure that that we are really dividing women that do not have disease, that they are not at risk of the disease, and those that they have a risk because they have the infection, then they can be observed in a referral center, and among those that they go to a referral center, then we can detect those by histology, by pathology that have the disease. So it helps really management in a more agile way. Another tool that has been extremely beneficial is to stop with cryotherapy, because cryotherapy implies to have sources of cryogas. This is, as you see, is very heavy, but as well it runs out. When you have X number of women, today the woman comes from far away, and then she has to have her treatment, which we do through cold. We put a probe into the cervix where there is the lesion, and it so happened that then there is no gas. So that woman has lost the day. That woman will not come back because will not trust the services. So now we have identified mobile approaches that do not need the cryogas, that they can use batteries or electricity. It's called thermal ablation. WHO is promoting this very much because it provides a treatment that it's easy, applicable, and it's less costly with the same efficacy that cryotherapy. And that's a big investment, and still many countries do not have this, and many providers do not know how to use it. And it's our battle, because there is no point to screen women if we are not able to treat them, and that's an important thing. So in terms of summary, and I know the audience is not gynecologists, but I would say that what we have in a big picture, we have vaccination, and we know now we are working on trying to see, instead of 3, now we know that we can vaccinate safely with 2 doses. There is a big group working several trials around the world trying to see if the vaccine could be as efficacious as the 2 doses with only 1 dose. And that will be fantastic, because it will provide many more vaccines to many more girls. The issues here are the production, which is limited, and particularly now with all the issues with COVID, we have a blocking system with production of vaccines, and the cost is always a limiting factor. The traditional cervical cytology with Papa Nicolau imply in low resource settings a loss of follow-up and a poor impact in low resource settings when there is not a proper follow-up. We think that self-sampling using molecular biology is going to be a successful approach, but we need to have 1 billion tests. And now, if we go to all the companies that produce HPV tests, we will not get 1 billion tests that are affordable. The cost of the test is high, and the cost only goes down when you are massively buying something. But still, countries have a lot of problems to procure low-cost tests, which are very limited. We are now working, particularly many groups, but at NCI we are working in trying to implement artificial intelligence approaches to triage, to explore those women that they had the infection, try to see whether they have disease in a way that could be easy performed, could be low cost, and could be done by non-medical but well-prepared professionals. We are a limiting factor that it's validation and training, and we are working very hard on this. And we plan that in 1 to 2 years, we could be able to launch this at many countries. I already mentioned the thermal ablation. This device is important, but we need people to be aware of that and to invest in training, because when thermal ablation is possible, it's very good, but sometimes women are not eligible for thermal ablation. We need training, training, training. There are not enough people trained in low resource settings to manage diseases. And finally, one of the major issues is the women living with HIV. There are some areas in the world where this is a big proportion of women, and still we do not have a proper way to solve a very efficacious screening and triage approach. Why? Because women living with HIV have an immune deficiency to control HPV infection, and these women have many recurrences, even with applying the tools that we use in the general population. I would just tell you that there are many institutions, many NGOs that, motivated as well because of this elimination campaign, are now providing programs, and they are intervening in many countries. I think there is a lot of activity, even with women living with HIV as PEPFAR. But it is important to see that we need to make sure that all these goodwills to intervene in the society, in allowing for women to be visited and screened for cervical cancer, is done in a safe scenario. So we know that COVID in many settings is a major issue still today, and that we cannot bring women in the hundreds. We have to provide a safe place with the logistics that are needed to make sure that women, by coming to have a prevention visit, are not infected. As well, we need to use the evidence-based knowledge that we are acquiring. We have now new developed guidelines from WHO and from IARC, trying to use the very best science that can be applied in low resource settings. And as well, we need that all these programs, all this goodwill to promote the elimination campaign are done on quality control and transparency. And with this, I will leave it. Just to those that they would be interested to learn more about HPV and cervical cancer are invited in November in Toronto at the international conference. Thank you very much.
Thank you, Andrea, and thank you, Glenn. Good afternoon, everyone. You've made it. I'm your final speaker, and we are almost there. So I want to thank all of you and all of our friends and colleagues on Zoom for your gracious attention. Here's the problem, friends. In a day-long conference, when you're the 22nd of 22 speakers, most of my notes have been crossed out. There's not a lot left to say. So let me just offer a few brief remarks about where I think we're headed, and then a closing thought. Let me review what I think the ethical agenda for the future is, which is the task that I was assigned. Broadly speaking, there are huge issues of global disparity. There's a lack of attention and funding on research for prevention and screening. We have serious issues around race, gender, and ethnic disparity, both locally and globally. We have a desperate need for a focus on equity. We have to attend to local context, local community, and local cultural variation. We have to attend to issues of access, environmental degradation, profound need for political leadership and social will to create accountability, to move policy and regulation forward. We have to commit to a sense of social solidarity. Jim Keenan called this out beautifully in regards to the panel from our cancer survivors. And we need to be moved by the suffering of others, as some have said. And all of this falls under a broader consideration of the social determinants of health. I'll stop there, but I could keep going on the topics that I think constitute the ethical agenda for the future that have been spoken to today. Those are from notes from all of you who have spoken to this group today. So let me shift gears and say that in addition to all these tasks, what I think maybe we ought to also consider doing is framing this work in the context of hope. Why do I say that? It's on my mind first because this week I teach in a medical school context at Loyola Chicago, and I run a program for students interested in thinking about medicine as a Christian vocation. And one of those students talked to me after one of our sessions to tell me that he's been diagnosed with an advanced stage cancer as a third-year medical student that is unresponsive to treatment. And he said to me, Dr. Hart, I think I'm going to need to think about what it means to not become a doctor. Which raised for me the question of hope. I think hope is very important, friends, as we wrap up a day like this. And I say that for a few reasons. The intractable, multifaceted nature of this problem, the global dynamic in which it manifests, will require tremendous energy from people like you who are working on it. And we also need to communicate hope for the people who are suffering greatly from it. So I want to focus on those two areas as we wrap up today. To talk about an ethical agenda for the future in the context of hope, for me, speaking as a theologian, as a person of Christian faith, in the context of a Catholic and Jesuit university that I love as a graduate, is to remember that a future in the Christian context is one in which God shall wipe away all tears from their eyes, and there shall be no more death, neither sorrow nor crying, neither shall there be any more pain, for the former things have passed away. This can sound like nice religious mumbo jumbo, but from the perspective of faith, this is the truest thing we can know. The strange thing about hope in the Christian tradition is that it's characterized by an already but not yet vision of the world, one in which we know that God's saving will is ultimately triumphant, but it's painfully not yet readily apparent. There are glimpses of it. I have seen grace today in the work of people seated in this room and joining us by Zoom, lives given to furthering God's goodness in the world. So there are these moments of inbreaking, but the work ahead of us remains significant. So to situate the global cancer pandemic in such a view of history, at least of Christian history, one has to begin with the idea that God loves us and loves creation, and that story ends in God's restoration and saving of us and God's creation. It's to be reminded that while the seriousness of the problem we've discussed today cannot be neglected, nor can our response be muted, we're called to remember that this life and its problems are not definitive of our hope and our fulfillment or our expectation. This is a foundational message for the Christian faith. Encountering the reality of suffering, the kind of suffering, Lauren, that you flagged in the fear that precedes a scan. As a graduate student here, my wife was diagnosed with melanoma during my graduate school years, and I had to walk over to Baptist Library where she was studying to take the bar exam to tell her that she needed to come back right away because the University of Iowa Hospital needed to talk to her because they'd lost her slides. And 2 months later called to tell her that they had a positive for melanoma and they had forgotten to inform her of that. So to encounter suffering without the knowledge of Christ in the Christian tradition of a loving God really emerges from a false understanding of reality. That has to be the place from which an institution like this begins to think about this question. And I think that Connor Kelly from Marquette today did a beautiful job of reminding us that our mortality has to be a place of beginning as we think about this question. Listen here to the words of Dietrich Bonhoeffer, the Lutheran pastor who was hanged by the Nazis in a prison camp days before that camp was liberated by American soldiers. Listen to what a voice of hope sounds like in a concentration camp. He writes, "The space of the church is the place where witness is given to the foundation of all reality in Jesus Christ. The church is the place where it is proclaimed and taken seriously that God has reconciled the world to God's self, that God so loved the world that God gave his son. The space of the church is not there in order to fight with the world for a piece of territory, but precisely to testify to the world that the world is still the world, namely that the world is loved and reconciled by God, as each of us are as part of that world." So what do I think that the church can do? What do I think that faith can do in the face of the cancer pandemic? The first thing it can do is remind us of this, a grounding reality from the position of faith that situates this kind of effort in our work in a context of hope, to know that we do have to work diligently at fixing it, but that ultimately God saves this. After reminding us of that, we are given a task, and that is one of accompaniment. One of the strange things about the Christian tradition is that we can probe God asking, why the suffering? Why is this allowed? And here I'm going to draw heavily on a wonderful theologian named John Swinton at the University of Aberdeen. John is a psychiatric nurse and a practical theologian who wrote a beautiful book that I actually teach to a subset of our medical students called Raging with Compassion. And it is a Christian theodicy looking at the question of human suffering. So most of what I say in this section is really coming from John. But what we see when we look at the question of the Christian God and the issue of suffering is that God responds to the world's suffering by joining us in it. It is a kind of radical and costly solidarity. You heard Professor Williams and Professor Keenan reference the importance of solidarity today. From the Christian context, the message of the cross is important insofar as it locates God firmly within the realm of human suffering. God's answer is not abstract condolence, but costly solidarity. As I heard Jim tell his story about asking friends to accompany him for those interferon treatments, I was reminded of a beautiful line from the professor Nicholas Walterstorff. He's a well-known, preeminent philosopher in the Western tradition. But interesting to me is the fact that Walterstorff lost a son to a mountain climbing accident when his son was 20 years old. And Walterstorff wrote a beautiful series of personal reflections that at the urging of friends became a book called Lament for a Son. And he has a line at the beginning of that book that says, "Do not tell me that death and suffering is not awful. Do not tell me it will be okay. Instead, come sit beside me on my bench of mourning." And that is the kind of solidarity that I think Professor Keenan and others of you have talked through. The gift of a husband, someone who's with you in it. Excuse me. And that is the story of the Christian God, a God of accompaniment. I think the obligation we have, and perhaps this speaks to what Professor Keenan was pressing us to consider. Cancer brings suffering, no doubt. But that suffering only becomes evil when we allow that suffering to separate individual persons from loving relationships, and the experience of God's love for us. And illness does that very effectively, and I think cancer does it very distinctly because there is a solitary nature to that endeavor. So how is it that we can resist suffering? Well, I can tell you that in Swinton's book, he offers us a range of beautiful Christian practices. I just want to call our attention to two that come to mind for me. One is Lament. The theologian Walter Brueggemann, scripture scholar, has written beautifully on the Psalms of Lament. And Swinton picks up this theme of the importance of part of the Judeo-Christian tradition being a whole body of prayers in which we are allowed to scream and rage at God, at the injustice of the question, why me? How much longer, O Lord? But as many of you know, the interesting thing about the Psalms is that they end on a note of hope and restoration. And part of what I think we are called to do in accompanying those among us who are on that journey of cancer is to be able to say the prayers of lament with them, so that if they cannot finish the prayer, if they cannot get to the restoration, we can say the words until they're able to join us in it. Another one is attention, and that is part of the grace of today. So my thanks to all of you who have put this conference together. So much of our experience of sin is a careless and casual and regular inattention. So much of what needs to be remedied is rooted in countless acts of selfishness and greed and inattention. Again and again and again today, I kept writing in the margin as I was taking notes on all of our speakers. It sounds to me like that we're just too selfish, so we're killing one another. And some of us are killing others of us more. How often today we talked about the challenge of changing people's hearts and minds, of moving past greed, of moving towards equity and justice, of knowing that there's enough to go around. As the Dominican theologian Herbert McCabe has reflected, the issue of human hunger is not about a lack of food, it's about a lack of generosity, right? There's more than enough food. Which brings me to my final and closing point, and here maybe I'm thinking about those of my colleagues here who are more than likely students. God knows you look much younger than I do, I know that. But I think it's true for all of us. The other thing that the Christian tradition can offer us, in addition to accompanying and reminding, is to help us sustain ourselves in this work. One thing that was clear to me in listening to many of my distinguished colleagues here today is that they know one another. They are friends. They are brothers and sisters in this issue together. They know one another's work. They know one another's frustrations. There is a sense of camaraderie and mutual support. And I want to flag how profoundly important that is for any of you, whether you're going to be med students or you're going to be bench scientists or you're going to be, you're going to go into health policy or become a nurse, whatever it may be. This is long and grinding work. Not because the issues are necessarily so complex, but because the issues are rooted in human decision-making and the capacity to change human will. And that is grindingly hard work. It's grindingly hard because from the perspective of this tradition, we're sinful and broken people. And one success will be met with another failure. We'll do good in this, and this will begin to fall apart. We'll make progress here, and we'll slip back there. And to be people who give your life to that kind of work requires profound hope so that you don't slip into cynicism. Cynicism is a defensiveness, right? It's a willingness to have been opened yourself to a grand project and to have been hurt by it, to have hit enough brick walls that you find yourself broken by it, so that you turn inward and closed off and you no longer give yourself to the big projects. One of the gifts of the tradition of this university, from which I have the privilege of speaking today, is that we know that in failure, there is redemption. So let me close with where I began. In a very, very strange way, God works in our failures as well as God works in our successes. So we have to be ready for defeat. We have to be ready for setback. We have to be ready for the endless challenges that will come our way with the confidence that all of this belongs to God and that in the end, God will work with everything that we are willing to give. And when we do that, we live up to the motto of this extraordinary university and its founders in the Society of Jesus, because then our work will truly be for the greater glory of God. Thank you, everyone, for your kind attention.
Thank you very much to Dr. Silvia de San Jose and John for this closing panel. I express my gratitude to our speakers who contributed by sharing their expertise and insights in person and virtually. To our moderators, to our students who presented the posters, and to all of you who participated in our conference in person or virtually. A particular thank to Professor Kurt Strafe and Professor Philip Landrigan for the opportunity of organizing this conference together as part of the program in Global Public Health and the Common Good, directed by Professor Philip Landrigan and under the Schiller Institute for Integrated Science and Society, led by Professor Laura Steinberg. Many people made our conference possible, and we are very grateful for who they are and for what they have contributed. The Institute for the Liberal Arts at Boston College, under the leadership of Professor Mary Crane, generously funded our conference and provided the needed organizational support and expertise. Our thanks to Shalonda Barton, Stephanie Querzuoli, Gori Pandey, Julia Barrett, Lauren Marshall, and earlier on, Jacqueline Delgado. The School of Theology and Ministry, under the leadership of its Dean, Professor Thomas Stegman, and the expert guidance of Maura Coleri, Associate Dean for Finance and Administration, generously allowed us to benefit from the competent help of 3 graduate students who are graduate assistants, Michaela Fulton, who handled all the Zoom issues, Victoria Costa, and Riley Armstrong. We are very grateful for their help and presence. The expert staff of the Media Technology Services, under the leadership of John Sage, address all technological issues and help us to assure in-person and visual participation with some glitches, but that's part of the business. The staff of BC Catering enrich our celebration and social interactions with their services, food, drinks, and beverages. Finally, we express our gratitude to Jason King and Therese Lizotte, who are directors of the Journal of Moral Theology, for accepting to publish the forthcoming volume that will gather the contributions of all our speakers today. In the Journal of Moral Theology, we'll publish today's contributions as open access first, and then they will appear in the printed volume published by the publisher Whipsam Stock in the series that we launched with the volume that presented the conference in 2019 in the series Catholic Theological Ethics in the World Church. So we follow what we did 2 years ago, publishing the proceedings of the conference on ethical challenges in global health, climate change, pollution, and the health of the poor. And we would like to continue this tradition with other conferences in the future. Finally, a special thanks to Professor Summer Sherburne Hawkins at the Boston College School of Social Work and Professor Joyce Edmonds at the Boston College Cornell School of Nursing for assessing the students' posters that were submitted. Now I invite you to join our closing reception and visit the students' posters that feature their engagements, their achievements in addressing aspects of the rising global cancer pandemic in our world today. So thank you again, and enjoy the reception and the students' posters.
I think we forgot one important thing. The most important thanks to Andrea Vicini, who really helped us to move this forward, and really without him, this wouldn't have happened. Thank you, Andrea.